Welcome to AETCM, the emergency medicine channel. Today's our topic of discussion from the upper GI bleed, that is a gastroesophageal reflux disease, GERD or D. So first one, regarding before going into GERD, we'll see some anatomical note regarding the esophagus. First one, esophagus or otherwise it's called as a food pipe. It is a connection between the your oral cavity to the stomach, right? It is one of the muscular tube. The length of this tube approximately it is about 20 to 25 centimeter, and then primarily it located in the mediastinal region, slightly lateral to the trachea with the smaller cervical and then abdominal compartments. So it have the same thing, it is regarding the layers or wall. So the same GI tract already we discussed. In GI tracts we have a first one is a mucosal layer, followed by we have a submucosal layer where all our blood vessels and then lymphatic system, all our nerves will present, and then followed by we have a one muscle layer, and then followed by we have outer thing is a serosa layer. So coming into muscle layer in esophagus, first in outer side we have a longitudinal muscle layer, in inner thing we have a circular muscle layer. So what will do? So while if the longitudinal muscle layer, while contraction of the longitudinal muscle layer, what will happen? So while contraction, the whole length of the tube will reduce. That is the action of the longitudinal muscle layer. So while contraction, the whole length of the esophagus will reduce. That is the action of the longitudinal muscle layer. So what will happen in the circular muscle layer? This is the circular muscle layer, right? So while contraction, it will contract and then it will relax. So thereby it will create a peristaltic movement. So that is called the circular muscle layer function. So this is the two major layer, and then coming into next part, the lining of the mucosa. So here we have a striated squamous epithelial cell. What tissue we have? A striated squamous epithelial cell. It is a closely attached flat type of cells or tissue we have in the esophagus. Majorly it doesn't have any secretory function. Okay, this is one of the thing. And then coming into next thing, that is a sphincter related. So to understand or reflect disease, we definitely should know regarding the sphincters. Sphincter is nothing but it is like a valve like action. It is not exactly valve, but it's like a valve like action. So muscle itself, its simple modification will be there in the continuity of the muscle. There it will be like a ring like a portion. So the muscle will modify simply, and then it will like a ring like a portion. So thereby it will act like a bodyguard. So it won't allow any unnecessary content into side, and then it will prevent the reflex back. So that is the action of the sphincters. Mainly we have two sphincters, that is a upper esophageal sphincters and then lower esophageal sphincters. So upper esophageal sphincters location wise, it will present behind or posterior to the cricoid cartilage. Okay, cricoid cartilage, it may extend into upper and then lower to the cricoid cartilage, but the primary location is posterior to the cricoid cartilage. Coming into lower esophageal sphincters, the location is the LES, that is your gastroesophageal junction. So where the esophagus meet with our gastric wall, that is called the lower esophageal sphincters. The other name for the lower esophageal sphincter is a cardiac sphincter. Cardiac sphincter. Okay, that is close to our heart. That's why cardiac sphincter. And what is the function of the both sphincters? For upper esophageal sphincter, it have a function like it will prevent air from entering the esophagus and food from reflexing into the pharynx. So it will prevent whatever content that is presenting from pharynx to the esophagus from esophagus to the pharynx. That is a one action in the upper esophageal sphincter. Coming into lower esophageal sphincter, it will prevent stomach content from reflexing into the esophagus. That is a function of the LES. And then coming into which muscle is representing upper esophageal sphincter. So here we mention like a cricopharyngeus muscle is representing sphincter for the upper esophageal sphincter. That is modifying cricopharyngeus muscle only, modifying like a acting like a sphincter activity. Here and that cardiac muscle sphincter, lower esophageal muscle only, lower esophageal muscle mean the same time some striated muscle of diaphragmatic muscle. Both are contributing in the sphincter activity for the lower esophageal sphincters. So the resting pressure around in the upper esophageal sphincter, it is somewhat around 100 millimeters in mercury, but coming into lower side, that is 4 times lesser with an upper esophageal sphincter, it's about 25 millimeters in mercury. So then coming into our topic regarding gastroesophageal reflux disease. So what is mean by reflux? Reflux means retrieve back, or you can tell as a regurgitation. So revert back, okay, that is called the reflux, right? Revert back, or you can tell as a regurgitation. So whatever content that is present in the gastric or stomach, that is coming or revert back to the esophagus, that is called the esophageal reflux disease. So what actually in normal physiology, normal individual or adult or pediatric cases, usually that or whatever content we have in our stomach, that will revert back for to the esophageal region, that is a normal function. So when it will become a disease means if there any problem in the that aggressive defensive factor. So we discussed in the peptic ulcer disease. So whenever the problem or imbalance between the aggressive and then defensive factors, on the time only the problem will arise, that is called the GERT. The same thing what we discussed in our PUD, peptic ulcer disease. So there also there will be a imbalance between the aggressive and then defensive factor. So imbalance means either there may be a increased acid protection or production, or there might be a decreased defensive factors like mucus secretion or mucosal layer, means that will cause the ulcer, that is called the GERD. And then causes wise, hiatal hernia is one of the cause. Hiatal hernia means the portion of the stomach that get enter into the thoracic cavity, that is a hiatal hernia. And then prolonged gastric emptying time, so that some of the medications like anticholinergics or any pyloric obstruction or high fat and then fiber food, diabetic gastroparesis, these are the things that will take prolonged or longer gastric emptying time. This is also one of the cause. Third one, agents that decrease the lower sphincter pressure. Already the pressure in the lower esophageal sphincter is a less in manner, but some other agents still more it is lessening, means easily the content get back into the esophagus, like medicines like nitrates, calcium channel blockers, anticholinergic, progesterone, estrogen hormone, and then high fat food, nicotine, pregnancy also one of the cause. Fourth one is a impaired esophageal motility. Motility means your peristalsis. So when it will affect means achalasia and then diabetic mellitus. So achalasia means what? Means achalasia means it is a one of the condition that will affect our motility, or that will affect our peristaltic, esophageal peristaltic movement. The causes might be because of any tumors or any lower esophageal disease, or because of any infection, or because of any nerve related, if any problem in the nerve signaling, means that will also affect our motility or peristalsis. So it is a achalasia is one of the cause. Diabetic mellitus also one of the cause, predisposing factor for the reflux disease. Then coming into assessment, this is a heartburn is a one of the predominant clinical finding in the GERD. So heartburn means epigastric region pain, tenderness, that is called as a heartburn. So what is the major important thing in a heartburn means, so our inferior wall MA also the person may feel a pain in the epigastric region. So before going into before getting into the management part, first we have to rule out whether that is a life threatening related one or non life threatening related one. Life threatening heartburn or epigastric pain, we told like it can occur in the inferior wall MI, or else it can occur in the any aortic dissection. So these are the some various red flag signs or symptoms, or red flag diseases also there, right? So that is why if the person complaining heartburn or epigastric pain, first you have to rule out the whether that is a life threatening one or non life threatening one. That is the first thing. Second thing, how we can differentiate means by asking the history, whether that is the pain is, how is the nature of the pain. If it is a aortic dissection means how the pain will be, it will be ripping pain, tearing pain will be there. If it is a myocardial ischemia or infarction means there the pain will be like a stabbing pain, the intensity of the pain will higher side. But if you are coming into our epigastric pain, coming with a GERT or peptic ulcer means it will be like a gnawing pain or something like a bearable one. It won't be like a that much of higher side, right? That is the one of the thing, nature of the pain we can ask. Second thing what we can do means radiation of the pain. So if it is a aortic dissection or myocardial ischemia means myocardial ischemia mainly that will radiate to the left side shoulder, the ulnar process, right, up to the till the finger, ulnar process finger it will radiate. But in the case of GERD, it won't radiate to the other side. Mainly the person will have a pain over the epigastric region alone. If it is radiating means, so if the disease progressing superiorly means mainly the person will have a discomfort or pain in the only in a medial region only, it won't spread to the lateral region. So this is one of the factor we can remember. Third one, mainly when the pain will increase, the person you can ask regarding while the time of the person taking food or water means at the time the pain will increase. If the person lying flat means at the time the pain will aggravate or the pain will increase. So these are the some factors we can ask for. Again, if you are administering any antacids or if you are administering any proton pump inhibitor or neutralizing agents or any other drugs regarding anti-secretory drugs means it will give us some palliation in the pain that will reduce your pain. So these are the some clinical findings or clinical assessment we can go for while handling a GERT. So again, management wise mainly supportive care in the nature. So the factors what we are going to consider is here the person will mainly complain the pain. Pain reason for the pain is because of the acidic nature or pepsin activity or because of the HCl content, the stomach content, right? So how we can tackle all this acid or stomach content or stomach acidity means whether we have to reduce the acid secretion or we have to neutralize the secretion. This is the management. So for reduce the acid secretion, we have a H2 receptor blockers like ranitidine, and then we have a proton pump inhibitor, pantoprazole, omeprazole. There is a common drug we can use, pantoprazole we can give 40 mg, or else we have a H2 receptor blockers like pyranozepine. Those are the drugs also we can go for. And then we have some antacids. So antacids, what are the things we have? If the person able to take orally means we can give some sucralfate. That's one of the thing we can go for. Or else we can, if the person unable to take means we can go for the systemic, that is soda bicarbonate also we can administer. The pain is one of the factor we are tackling in the pre-hospital scenario. Still more other management, if the person have a what are the dietary advice we can give to the person means education related, we have to ask the person to avoid something exacerbate GERD like ethanol, caffeine, nicotine, chocolates, fatty food. So those are the things it will take a larger time to the gastric emptying. So we have to ask the person to avoid those are the things. And then while sleeping you have to ask the person for the head and elevation 30-degree, and then we have to ask the person to avoid within 3 hours of going bed at night time. So because of the gastric secretion, so while sleeping they will used to sleep in a flat position. So again, if the because of the gastric secretion, it will get a chance for the reflux. So this is the common advice we can give. Prokinetic agents, antiemetic also we can try in this case. So antiemetic ways, there are two major groups we are using. First one is that 5-HT3 antagonist or ondansetron, emisset. So compare with an emisset, we can go with an metoclopramide. This is one of the advisable agent in the case of GERT. So what is the action of prokinetic agents? So it will increase the kinetic activity in the lower esophageal sphincter, right? In a lower esophageal, it will increase the lower esophageal tone. So thereby lower esophageal tone will increase means what will happen? It will stimulate your stomach. So thereby your stomach content also easily get fastly it will evacuate the or it will shift the content into the duodenum. That is action of prokinetic agent or metoclopramide. That is the reason they are recommending metoclopramide also we can give 5 to 10 mg we can based on that person condition or based on our online medical direction we can go for this metoclopramide also. So do your best. Shalom.